morning and welcome to the Myocarditis Foundation Zoom call family meeting. We'd like to thank you all for taking your time from your Saturday to be here with us today. This meeting has been made possible by our three supporters, Canixa Pharmaceutical, the Kennan family, and the Trilogy Group. They have chosen to support our meeting because they believe that all patients should have access to medical experts in the field and up-to-date information on myocarditis and pericarditis. I'd like to introduce and tell you a little bit about myself. My name is Genevieve Ramori. I've been the Executive Director for the Myocarditis Foundation for the past 6 years. I am a registered nurse with more than 45 years of experience. Many of those years were in cardiac and emergency room nursing. Also with us today are the two co-founders of the Myocarditis Foundation, Dr. Leslie Cooper, one of our panelists, and Candace Moose, a giant cell myocarditis survivor and heart transplant recipient of almost 20 years. Candace, would you like to say a few words to our audience?
I would. First of all, thank you to our esteemed panel for giving up of your time to help us help families and patients from all over the world. The Myocarditis Foundation has been a labor of love for me for the past 20 years. I came to know Dr. Cooper because he participated in my care as a giant cell myocarditis patient, and it was his research that saved my life. When I recovered, I said to Dr. Cooper, what can I do to help you? And he said, we need to start a foundation. And this day, with a Zoom call with these incredible experts and with all of you on the call, is a culmination of 20 years of our effort. And I thank you all for being here.
Thank you, Candace, for your desire to help others by starting the foundation with Dr. Leslie Cooper. You have helped so many over the past 16 years and continue to do so. Today is our third virtual family meeting in the past 6 months, and we have an ever-increasing number of participants. Perhaps this is one positive outcome of the COVID-19 virus, the awareness and popularity of virtual meetings, allowing us to get together with people around the world to discuss myocarditis and pericarditis, two rare diseases that often go hand in hand. Hopefully, we will be able to get back to our in-person family meetings sometime soon. Today, we have almost 90 participants from 8 different countries. We hope that you are comfortable and have your morning or afternoon beverage of choice with you, depending on what part of the world you are in, as you listen to our esteemed cardiologists respond to the questions that you have sent in. I do need to remind you, though, that this cannot be a personal consultation of sorts. The doctors will try their best to give you as much information as they can without getting specific to each of your cases. We ask that you please wait for the last 30 minutes or so of the meeting before asking any additional questions you may have on the chat screen. Your question may already have been answered throughout the discussions. We will attempt to answer as many of your questions as we can. I would like to take this time to announce our esteemed panel of cardiologists, many from our board of directors and medical advisory board. Dr. Leslie Cooper, Dr. Enrico Emirati, Dr. Massimo Amazio, Dr. Jack Price, and Dr. Justin Godown. I will let them each tell you a little bit about themselves. So let's start with Dr. Leslie Cooper.
Thank you, Jen. And it's a great pleasure to be here with you today, again, for our third of these virtual meetings. I share your hope that we will get back together in person later this year or in the not so distant future. I first became interested in myocarditis through the tragic death of a young woman who was admitted to my cardiology service when I was a medical resident 28 years ago. And that impact changed my focus in my academic and my personal career, and over time led to specifically a desire to help giant cell myocarditis in the beginning decades And then as time went on, that spread. And with this foundation, we've been able to impact the lives, I think, of many people with all forms of myocarditis. We've been able to help more than 22 individuals through research grants. And we've been on a monthly basis, more than 30,000 individuals will log on to our website for information. So I'm the chair of cardiology at the Mayo Clinic in Florida, and that's why I'm here.
I'll go next. I'm Jack Price. I'm a pediatric cardiologist in Houston. I'm a professor at the Baylor College of Medicine here in Texas. And I've been practicing pediatric cardiology now for about 25 years. I first became interested in pediatric myocarditis while caring for, very acutely ill pediatric patients in the ICU. It's a passion of mine to be able to educate both patients and their families about this disease process. And as I'm learning more and more, it's just as important to be educating other care providers, physicians, nurse practitioners, for example. And Jen and I have done a fair amount of that through the foundation. And I think this is just another good example of how we can continue to educate the public. So looking forward to it today.
I'm happy to go next. So my name is Justin Godown. I am a pediatric cardiologist like Jack, and I work at Vanderbilt Children's Hospital in Nashville, Tennessee. My focus is on pediatric heart failure, heart transplantation, including many patients with myocarditis. And I am one of the newest additions to this group. So thank you for inviting me.
So I'm Enrico Mirati from Milano in Italy, and I'm really happy to join Myocarditis Foundation. Thanks to everybody in the foundation. Thanks to Leslie Cooper that I had the real pleasure to meet some years ago. I have to say I'm an advanced heart failure specialist and a heart transplant specialist. And also in my case, I was fascinated by this disease when we managed for the first time a patient with giant cell myocarditis that who recovered after 21 days on temporary mechanical circulatory support, thanks to these drugs like anti-thymoglobulins that Leslie proposed in the past as an effective treatment for giant cell myocarditis. I was really impressed by this case, and so I started my career, my research clinical career on this theme, and then we developed studies and registries on fulminant myocarditis. So that means myocarditis with the hemodynamical instability. So this is the cases with the high rate of mortality or complications. And I'm currently involved in a randomized clinical trial assessing the role of corticosteroids in the treatment of patients with severe myocarditis complicated by acute heart failure or cardiogenic shock. So it's a pleasure to be here with you today, and I hope also in the next meetings.
That's it? Okay. Dr. Massimo Imazio, I think is not with us. So we will move on, and I'd like to thank you all for sharing your prestigious medical backgrounds and for being here with us today. We have had many questions asking about the different types of myocarditis. Some people not having had giant cell would ask, what exactly are these giant cells? And people who are asking about lymphocytic myocarditis and viral and what the differences are. So as an introduction of sorts, before we get started, Dr. Leslie Cooper has offered to give a brief overview of the various types of myocarditis. This way, you all will better understand when questions are asked about a type of myocarditis that may not sound familiar to you. Dr. Cooper, you can share your screen now, and thank you for doing this for us.
Well, thank you, Jen. And I'd just like to take a few minutes. I'm not going to use slides today, but I'll simply say that from a patient perspective, there are several ways that myocarditis can present, and those ways have very different outcomes. The first is with the chest pain syndrome, and many people on this call who have had myocarditis perhaps presented with chest pain at their very first symptom. If your heart function is good and the chest pain is from inflammation of the pericardium with a little bit of heart muscle damage, the outcomes are generally excellent. But in contrast, some people present with heart failure, which is a clinical syndrome of shortness of breath, sometimes with fluid retention. And when the heart pump is decreased, that's often represented by the left ventricular ejection fraction being low. If it's quite low, then the outcomes are much more serious. And furthermore, the third group is what Dr. Amirati has studied extensively, fulminant myocarditis. That's when the pump function is so low that you need special medicines, often intravenous medicines to support the heart function, or mechanical pumps like an intra-aortic balloon pump, for example, or extracorporeal oxygenation device. So those are the three groups: fulminant, which has a pretty serious outcome; heart failure without those heart rhythm or heart block complications, which is in the middle; and then the chest pain group. There are other ways that we categorize myocarditis besides clinical presentation, and those include what it looks like under the microscope, or histology. In histology, the most common form is with simply white blood cells or lymphocytes, lymphocytic myocarditis. And that can represent a wide variety of infections or inflammatory causes. It's not specific to any one etiology or cause. But then there are some specific disorders like giant cell myocarditis. It's pretty rare, about 1% of all myocarditis in adults, but it has a very serious outcome. And the giant cells are the fusion of these macrophages into large groups. It's a very unusual pattern. It's quite distinct. And the remarkable thing is it almost always presents with that fulminant form of myocarditis that Dr. Amirati studies. And so there are other forms. There's some, and they're characterized by specific cells or patterns of cells. You may hear cardiac sarcoid or granulomatous myocarditis. That's a pattern of cells. Or eosinophilic myocarditis, another disease that Dr. Amirati has pioneered in the last 5 years. That is characterized by a special cell called eosinophils in high numbers. Again, it's not important to recognize each of those, except that the really bad ones tend to be fulminant or have heart rhythm problems. And those are the ones that need a biopsy. So with that very brief introduction, I'd like to share the stage. And Jen, would you kick it off with some questions?
Sure. Let's get started with the questions that you have sent in to us. Basically, Dr. Cooper has given you the brief types, in brief, the different types of myocarditis. But people have asked, is there a standard treatment for myocarditis? And should people be on medications after a diagnosis of myocarditis or pericarditis? Or is it common to not be on any medications?
You know, Enrico, you published a really great paper last fall, all about the management in our consensus statement. Maybe you'd want to start with that first question.
Yes, thank you, Leslie. I mean, there is no specific therapy for myocarditis based on consensus, or based on medical evidence. At least it is what we call evidence. It's a randomized clinical trial where you demonstrate that a therapy is superior to the placebo or comparing it to another drug. And in the field of myocarditis, we are not able to say this therapy, that can be an immunosuppressive drug, is for sure more effective than not doing anything and just wait for spontaneous recovery. At least in the most common form of myocarditis, that is the viral form of myocarditis. What is a viral form of myocarditis? Is a myocarditis that is a consequence of a viral exposure. And in most cases, a viral myocarditis has an lymphocytic infiltrate. As previously Leslie said, that the fact that you find the lymphocytic cells in the heart is not specific. It can be the result of a viral disease. It can be the result of an autoimmune disorder. And of course, if the myocarditis occurs in the setting of an autoimmune disorders, then the treatment can be an immunosuppressive therapy that follows the indication for the reacutization of this specific disease. But when you have isolated acute onset myocarditis, there is still debate on what is the best treatment. So if you present with a fulminant myocarditis or with heart failure, the first line of therapy is to support your circulation, so to make the person to survive. Then there are potential therapies based on the histology that we found in the heart, based on what is called endomyocardial biopsy. That is a way to sample with a tiny specimen of the heart, the affected heart. And you can have an eosinophilic myocarditis characterized by these eosinophilic cells. And in this case, steroids are thought to be effective. Or you can find the giant cell myocarditis. And as this myocarditis is considered an autoimmune disorder of the heart, several lines of immune suppressive therapy are considered effective. While if you have a cardiac sarcoidosis that rarely presents as an acute myocarditis, again, corticosteroids can be effective. While if you have a lymphocytic myocarditis, we are not really sure what is the best therapy in addition to the supportive treatment, but we believe that at least in some patients with the more severe forms, corticosteroids can be useful, even if this is a theme of our current research to check if immunosuppression can provide benefit, at least more benefit than risk related to potential superinfection related to the administration of immunosuppressive drugs. It can be that in more severe condition, devices are used. And when I say devices, are sort of devices that are used to support the circulation. And we have different kind of devices that we used in the sickest patients. Then we have other drugs that can prevent or can cardiovert the heart in case of arrhythmias, in particular ventricular arrhythmias, because Leslie told you that there is the risky complication is heart failure, but unfortunately heart failure can be even more complicated by ventricular arrhythmias that can cause also sudden cardiac death. So specific drug that prevents or treat arrhythmias are administered during the acute phase. While if there is no complete recovery after the myocarditis, then heart failure treatments are administered, and these kind of therapies are quite standardized, because in this case, patients that had or a myocarditis or have a chronic inflammatory cardiomyopathy, I mean after the acute phase, are treated as other patients that suffers from chronic heart failure. So this medication in this case are quite standardized, because they have been proven by randomized clinical trial. So I'm not going in the details of these drugs, but there are several categories of these drugs, like beta blockers, ACE inhibitors, or anti-aldosterone medication that are very effective.
Thank you. Thank you very much for that, Dr. Moretti. Perhaps we should jump to the pediatric cardiologists for a moment. And we know that it's very difficult to diagnose any kind of condition in a child, because they really can't explain their feelings for the most part. But parents were wondering if there's any signs specific that they should be looking for. And is there a best way to treat it, and how fast should action be taking? And if I'm messing up this question, what can parents look for early on, and is there a quick action that should be taken in the treatment of viral myocarditis with children?
Yeah, I'm happy to start off with that. Unfortunately, there are no signs or symptoms that are unique to myocarditis in kids. And that's part of what makes this so difficult in our patient population. As you mentioned, Jen, a lot of these kids really they don't have the verbal skills to articulate how they feel, what kind of symptoms they're having. So we have to rely on parents. And parents are pretty astute. And what I've noticed is that when parents bring children in and we find that they have myocarditis, a lot of times it's situations that are different from the typical viral syndrome type symptoms that they've experienced before, maybe a more severe presentation of their case. Usually when we have kids come to the emergency department with new cases of myocarditis, they have symptoms such as a decrease in their appetite. Maybe if they are feeding, they're vomiting. They may be complaining of abdominal pains, fatigue. Sometimes the older kids may be complaining of shortness of breath. Sometimes we can elicit what we would call a viral prodrome, meaning a history of a recent viral infection in the preceding 2 weeks generally in these kids. But there's not a specific sort of set of clinical signs and symptoms that we can hang our hat on and say this is myocarditis. Instead, we have to have a suspicion that a kid presenting with these signs and symptoms might have myocarditis. And we have things that we can test for that can lead us down that pathway. Starting off with a physical exam. So, we have certain things we're listening for when we listen to the heart. We have certain things that we're feeling for when we examine the patient's abdomen. An enlarged liver, for example, fluid accumulation in different parts of the body, and like I said, abnormal heart sounds. And then we have testing that we can do that can also help us formulate a diagnosis. An echocardiogram is a test that looks at the motion and anatomy of the heart. An EKG looks at the electrical activity of the heart. Both of these tests can raise suspicions for people, for physicians, if they think a patient may be exhibiting signs and symptoms of myocarditis. Chest X-ray, although this is not absolutely reliable, but about half the cases, we're going to see evidence of fluid in the lung fields and more likely some degree of cardiac enlargement. And then a couple of blood tests that we can do. One is the BNP test, B-type natriuretic peptide. This test is almost always elevated in pediatric patients with myocarditis, and usually it's quite elevated, normal being less than 100, and our patients with myocarditis is generally over 1,000. Another test that we can look for is something called troponin, which measures injury to the cells of the heart, and this is frequently also elevated in patients with myocarditis. So those are some of the clinical features of myocarditis in children, but unfortunately they mimic normal childhood diseases like pneumonia, respiratory tract infections, asthma, the stomach flu, for example, those sorts of things. And so, we've described misdiagnosis in children here at my own institution, and about half the time that patients come in with new onset heart failure, these kids are misdiagnosed with something other than heart failure. And frequently they undergo an extensive workup, sometimes quite invasive. They're treated with other therapies that have nothing to do with heart failure or myocarditis. And the diagnosis is then even further delayed. That's pretty classic. And it just goes to show how challenging it is for frontline care providers to be able to distinguish this from other common childhood illnesses. Justin, I don't know if you have anything else you'd like to add to that.
So that's a really great summary. Just to add to that, so viral infections, are so common in children. And the vast majority of children who present with a viral infection are not going to have myocarditis. And so for the physician, picking that needle out of the haystack, saying, well, which child with some viral prodrome has myocarditis is extraordinarily challenging. And certainly, we're not advocating to send these tests, so do echocardiograms, EKGs on everyone, but really you need to start with that suspicion. So something's different about this patient, and the physician really needs to key in on that. The other thing to add to what Dr. Price said is, the age spectrum in pediatrics presents a challenge. So really there's two populations that we normally think of are kind of the most common in pediatric myocarditis. So sometimes we'll have kind of infants, so very young infants present with myocarditis, and obviously they can't tell you anything. And so we're relying a lot on the parents to tell us, well, something's not right. The other thing is, well, what can we assess based on an infant? And that's really feeding. So are they not feeding? Are they not peeing appropriately? Are they breathing a lot faster? So those are the things that we would typically look for in infants to kind of clue us into that diagnosis. Then the other population is kind of older children, so adolescents who can present with myocarditis. And that population is a little easier to some extent because they can actually tell you what they're feeling, report chest pain or any other symptoms going on.
Are there any advancements in the medical care for children diagnosed with myocarditis? Do physicians, especially like emergency room physicians, when a child comes in, say a teenager with chest pain or back pain or shortness of breath, is there more awareness for these type of complaints in children to be looked at a little more than, say, in the past? Because I know automatically they would have been assigned, oh, you're an athlete, oh, it's asthma, or oh, you must have pulled a muscle, or you're 16, you can't possibly have heart problems. Do they tend to look a little more further nowadays? Is there more awareness out there? I know the word myocarditis has gotten out more because of COVID especially, but is there anything that you're aware of helping emergency room physicians say to look more towards the possibility of could this be more than just what I think it is?
So I can try to address that. So that's a really difficult question to answer. I think that's something that's really hard to assess. And do I have data about, are physicians more aware of this diagnosis? I'm not aware of any such data. What would be my just overall impression? I suspect that physicians are aware of it, especially as you mentioned, COVID. This is really on the top of their minds right now. And so I think it's becoming increasingly a consideration for emergency room physicians. But when you think about it, what's common is common. What do they see all day, every day in the emergency department? Lots of viral infections. And so it still presents that challenge is, how do you identify that one patient who's going to develop myocarditis? I'd like to think that it's on their minds and they don't want to miss it, but it really takes an index of suspicion.
Thank you.
Yeah, it's interesting. I was just discussing with Candace how the viral infections this year are very different from previous years. And I think that's impacted on the type of patient that we hospitalize, at least in the past 12 months on the pediatric side. So for example, last year, I hospitalized several kids with influenza who also had clear evidence of myocardial involvement or maybe even myocarditis with influenza. This year, at my institution here in Houston, we performed over 1,000 influenza tests from November to February. And normally we have several hundred that come back positive. This year we had one single case of influenza in pediatrics here in Houston, at least at our hospital. And so you can see how that may impact on the incidence of myocarditis at any given institution. I don't have hard data to say that our numbers are down this year, but anecdotally, it feels like it. That's just as far as myocarditis, run-of-the-mill viral myocarditis goes. We're certainly seeing a lot of COVID patients, and we definitely have seen cardiac involvement with them. But the viral picture has changed over the past 12 months, generally speaking, and I think that has also impacted on the kind of cardiac patient we end up seeing because of that. Jen, you asked at the front end of your question about advances in medical care for children who have myocarditis.
Yes.
And I've had this question before, and I'm always kind of embarrassed, honestly, to try to answer this question because for a long time we haven't seen, I don't think we've seen significant advancement in at least the treatment of myocarditis specifically in kids. Yeah, we've had new ways of diagnosing it. I think cardiac MRI, for example, has come a long way on the pediatric side in the past several years. It's become, I think, more reliable. We feel more confident in our ability to diagnose using cardiac MRI. And so that's played a significant role, and we've seen that change and how it's impacted on biopsies. We're doing far fewer biopsies than we did, 10, 15 years ago. Instead, we're replacing that with cardiac MRI. So that's one change. Another change goes to the management of heart failure that occurs as a result of myocarditis. So Enrico talked a little bit about how you can support a patient with pumps, for example, and different medical therapies. And we've seen advancements on the pediatric side with that. So we're now using smaller and smaller pumps, both in the acute early phase of myocarditis to rescue someone, but also in a longer sort of chronic phase of heart failure that's resulted from myocarditis. And that includes medication. Just recently, the FDA has approved a new medical therapy for heart failure in kids. It's been approved in adults for some time. It's called Entresto. And so we're just starting to use that now in pediatric patients. It comes in a liquid formulation, so our smaller patients can take it as well. But those are some of the small sort of baby steps forward on the pediatric side with advancements in heart failure related to myocarditis, but no specific therapies just for viral myocarditis.
Thank you. Thank you. There have been some of our audience asking if there's anything that they can do nutritionally to minimize the risk of recurrent myocarditis or pericarditis. I guess nutritional supplements possibly. Is there anything that you're aware of that can help support the immune system and possibly help prevent people from developing myocarditis? Or if you have it, to improve faster?
For
Any
sure.
ideas?
Well, Jen, that's a great question. And Dr. Massimo Imazio, who is one of the world experts on pericarditis, was going to join us today, but in his absence, hopefully we'll see him at a future meeting. Let me take that question. After an episode of acute pericarditis or myopericarditis, when the myocardium is also involved, the risk of a recurrent episode is about 10 to 15%. And it's a great question. Is that in part related to environmental causes? We do think that in some of those cases, there will be a genetic basis. Perhaps there are these genes called desmosomal protein genes, which can be have variants. And that's a new area that's just coming out. That isn't in the clinic yet for routine testing, but we don't know of any nutritional deficiencies such as selenium deficiency or mercury exposure that might increase your risk of specific pericardial inflammation. You know, it's always good to follow a healthy Mediterranean diet, I would say, Enrico, a nod to healthy people in the Mediterranean basin, maybe as well. That actually is the basis of the Mayo diet as well, a Mediterranean diet. But I don't think there's anything specific in terms of a supplement that you should take.
Okay, and then there were also questions on what are the effects of alcohol and marijuana on myocarditis and pericarditis? Is there any knowledge on either of those that you'd like to share?
Enrico, you might want to take that one
Yes.
briefly, or I can,
Yes.
whatever.
I mean, when we talk about food, you have to consider that it's a rare form of eosinophilic myocarditis that can be transmitted by raw meat. So it's very rare, but so sometimes raw meat can cause an eosinophilic myocarditis due to this agent that is pathogen that is called Toxacara canis. It's very specific, but sometimes some food can cause the myocarditis. It must be said that it's very rare, so you can still eat raw meat even if it's not suggested. And regarding alcohol, what we can say, if you have a cardiomyopathy as a result of myocarditis or related to a chronic inflammatory cardiomyopathy, and the difference is that when you have a chronic form or of inflammatory cardiomyopathy, means that the agents, the mechanism that cause myocarditis persist, like in myocarditis associated with an inflammatory or an autoimmune disorder. So if on top of that you add also alcohol, that's not good, because we know that alcohol can worsening heart failure, or can even causes heart failure. Of course, the point is, as everything is the quantity. If you drink a lot, or if you drink spirits, then can be more dangerous than that just drink a glass of wine. So it makes a big difference if you drink spirits, or if you drink a large quantity of alcohol, beers or wines. And about marijuana, we do not have a lot of data. there are very, very rare case reports that occasionally can cause some forms of allergic myocarditis. So, and this form of allergic myocarditis in the end can be caused by almost everything that we eat or we take, even medicines. But again, I do not suggest marijuana for the therapy of myocarditis in any case.
The reader or the person who posed the question might have seen the clinical trial on clinicaltrials.gov looking at purified CBD, which is a component in marijuana, but it is in the trial, it is pharmaceutical CBD. It is not derived from the plant directly. And so, and obviously in an organic plant, there are thousands of molecules, and many of them are could be harmful as well as helpful. So there isn't data to say that the use of marijuana improves myocarditis. There is one animal study in a trial that's going on, has yet to be enrolling. So I don't think that that jury is very much out, but the study is on purified pharmaceutical grade CBD, not on marijuana.
Thank you for that clarification. I hope that helps the few people that did ask those questions. You spoke about heart failure. There's a question concerning, does myocarditis eventually lead to heart enlargement or other conditions as one ages? Will it affect my lifespan? And what's the likelihood of me developing myocarditis again once I have it?
Well, again, I don't want to answer for the pediatric population because I think there's unique data that comes from Australia and the NIH registry. Steve Lipschultz and others have published, and I defer for the pediatric answer to Jack and Justin, but for Enrico, who has actually studied recurrent myocarditis, I would simply say that if you look at all patients who present with a dilated cardiomyopathy, which is about 10% might have myocarditis by classic criteria, and a higher percentage using different immunohistologic criteria, which is the way you test heart muscle cells under the microscope for inflammation. But the likelihood of that progressing to a chronic heart failure is about 20%. And the range, these studies have been done in small cohorts for more than 50 years. And the range is from 0 to 52% with an average of about 20% in the collection of all those small studies. There certainly is a risk, but I wouldn't say that it is age, at least in the adult population, if you're 30 or 40 or 50, I'm not sure there's a difference in that risk. In the pediatric population, there may be, and for the recurrent question, which is specifically recurrent myocarditis, I defer to Enrico, and for the pediatric part, maybe Jack and Justin have contributions for that.
Anybody? No?
I think Jack's talking, but I think
Sorry.
he's muted.
You're on mute, Jack.
Sorry about that. I'm back with you. I was just saying that unfortunately and frustratingly, our ability to prognosticate depends on our ability to diagnose. For both adults and pediatrics, and that's especially true for us. If we're limited in our ability to make an accurate diagnosis in a small patient who maybe didn't have a biopsy, for example, to make their diagnosis, or we felt they were unstable to undergo MRI for whatever reason. But I'm going to quote you some data here that came out of the International Society of Heart and Lung Transplant a few years ago, and it was considered contemporary at the time, looking at prognosis at least at 1 year for follow-up. And they found that 15% of those pediatric patients required readmission to the hospital within 1 year, 5% had died by 1 year, 10% had gone on to be transplanted, so a heart transplant, and 35% of those pediatric patients continued to receive heart failure therapies. Not all of them, were symptomatic with their heart failure, but many of them probably did have abnormal or depressed cardiac function who are still being followed. And I think those numbers sound pretty reasonable, and Justin, they probably sound right for Vanderbilt, I'm guessing as well. And so the good news is for pediatric myocarditis is that this is a salvageable disease process. And fortunately, many, if not most of our patients go on to have some degree of recovery, if not complete recovery of cardiac function. And so those patients who end up with chronic heart failure or who need to undergo heart transplant, those are the minority of pediatric patients, fortunately.
Good to know.
And I will add to that just a little bit. So I agree completely with Jack about what he said, and those numbers do seem very reasonable for what we see. The other thing is what I think about with myocarditis is the heart has sustained some damage, and how much residual salvageable heart muscle is there, and is that enough? And so we have a lot of patients who, yes, they do recover function, some completely recover function. Yeah, I still continue, and I don't know what Jack's practice is, but I still continue to follow those patients, especially through adolescence when there's a growth spurt, because you can have kind of a burnt out picture where down the road, they've sustained some damage, and over time, the heart can't keep up with the demands of the body. And so we have seen some cases like that too. And I don't know, Jack, do you see that? And do you continue to follow patients long-term?
I do follow them long-term. I don't have a lot of data to support what I do. You know, if they normalize their heart function, I may back off on their visits to every couple of years. And I will follow them with surveillance echo and surveillance Holters. Maybe that's a little bit overkill on the Holter if someone doesn't have a previous arrhythmia history, but I will follow them that way. The early follow-up, if I have someone who wants to be a student athlete and compete, you know, in scholastic sports, I will have them run on an exercise treadmill test and just make sure their heart is healthy for extreme exertional activity, usually within the first 3 to 6 months after resolution of the acute phase.
Okay.
And Jen, are there any, so Jack kind of segued into exercise a little bit. Were there any questions specifically towards exercise?
Yes, actually, there are. When is it okay to resume activity after diagnosis, and can lifting of heavy weights or endurance training increase the risk of reoccurrence or cause complications?
So in the pediatric patients, what I usually tell my patients is 6 months. And depends a little bit on the course, but for the most part, I say if you have been diagnosed with acute myocarditis, we don't want strenuous exercise or competitive sports for 6 months. At the end of that 6 months, depending on the presentation, sometimes I'll actually ask them to do a treadmill test, like Jack had kind of mentioned. As far as heavy weightlifting, again, it depends a little bit on the course. If someone still has depressed function in any way, shape, or form, I usually recommend avoiding what's called isometric activities, which are basically lifting activities or things that involve a lot of straining, as that is going to increase the workload on the heart. For patients that have recovered function, I don't necessarily restrict them from that, and usually just those with depressed function. I don't know what if others have comments or do things differently or similarly.
I just say, when we wrote the 2015 AHA scientific statement on return to sports for myocarditis, the standard was 6 months. The ESC myocarditis position statement from 2013 recommended 6 months, as did the 36 Bethesda Conference, which was the previous document from the American Heart Association and the American College of Cardiology. So we modified that based upon one area, that there were some people with mild myopericarditis, young men who would come in with the chest pain syndrome. The chest pain was mainly pericarditis, but they'd have an elevated troponin, be treated with appropriate medicines, which could include colchicine or other similar anti-inflammatory medicines. And after 3 months, it seemed that that was an adequate duration of time to return to, after appropriate testing for arrhythmias, go back to competitive sports. So we wrote the range was 3 to 6 months. But of course, that with the intent of that was not to have people with bad heart failure go back to full competitive sports at 3 months. The intent was to allow for the mildest cases to be cleared before 3 months. I think before 6 months, I'm sorry. And so there are some people who might go beyond 6 months, but 6 months is usually the minimum if there's a bad heart failure. Enrico, I don't know, in Europe, do you ever clear people with a treadmill before 6 months if it was mild myopericarditis, or do you wait the full 6 months?
There is a huge variability in Europe, you know, but and even in Italy. It's based on opinion of experts and also on the habits of the center. And what I do generally is to check for troponin. Troponin is a biomarker, and so troponin must be in the normal level after 3 or 6 months, or at least before resuming physical activity, because we know that even if some chest pain, myocarditis presenting with chest pain, we must be sure that the inflammatory process is ended before resuming sport activities. So troponin can be a way to do that in association with for instance, a normal echocardiogram. If troponin is increased, or if I had more doubts, I repeat after 6 months, or between 3 and 6 months, a cardiac magnetic resonance imaging. And even if a residual scar is very common after a myocarditis, I have to be sure that there is no residual edema. So if there is no residual edema on cardiac magnetic resonance, I can suggest to resume physical activity even before 6 months. Again, to perform a treadmill test varies based on the kind of activity that that child or person is used to perform. I mean, if I said I go just to the university, I do not practice a lot, in my view it's not really necessary to perform a treadmill test to reassure a person. While if I have a child or a young adult that tell me I do a lot of physical activity, in that case I suggest to perform a treadmill test, and in particular to exclude the presence of arrhythmias during a treadmill test, even if also ECG Holter monitoring can be very useful. If I see that there is a high burden of ventricular premature contraction, then I ask for more evaluation. Okay, for instance, as I said before, I repeat a cardiac magnetic resonance. I check for troponin levels. And another point that I would like to introduce is the fact if this patient had previous myocarditis or previous pericarditis, or if this patient has a family history of myocarditis or cardiomyopathies. In these cases, I follow these patients with more attention, comparing with other patients with only an isolated myocarditis. And in this case, I suggest to to wait for a longer time before resuming physical activities, or I check more deeply in this case.
Thank you. We brought up, it was mentioned about scar tissue. There has been questions asked, will that scarring on my heart ever go away? And is a PET scan or an MRI better to diagnose myocarditis?
There are a couple questions in that. Number one, when scar forms following inflammation, it doesn't always go away, but it remodels. And so you can get a gradual healing and an improvement in cardiac function for a few years down the road through other mechanisms that remodel scar at a very, very slow rate. So the short answer is no, it probably never goes away completely, but it can change, and the change can be seen on MRIs as well. PET scanning is versus MRI for the diagnosis of myocarditis is a little bit of a complicated question. Let me say that the sequences that we use on MRI for scar have been established for a long time because of heart attacks. Heart attacks cause scar, and those were well described more than 20 years ago, and they've been refined and improved since that time. MRI is also useful for more acute inflammation, which is not scar, because there are other sequences which can be used specifically if you have the right software. I would say that there are three major manufacturers of MRIs, and they come in different levels. There's 1.5, 3, and 7T MRIs, and it depends on what MRI company and what software and what strength it is. There's a lot of nuance, and you need a place that's used to reading MRIs to get the right reading. The PET scan is also a little bit complicated, and this may be too much information, but you can use, it's a kind of nuclear imaging in which you can measure glucose metabolism, which is higher in inflammatory cells than in healthy muscle cells. But there are other reasons why you could see a lot of glucose in the heart, including normal heart function. So if you eat a donut and there's a lot of sugar in the donut, your heart's going to eat that glucose. For the muscle cells in the heart will use the glucose, and the heart will look like the whole thing is inflamed, as opposed to, because there's high glucose. But if you starve the heart for glucose for 24 hours with only fat or protein and no carbohydrates, and then you fast, you can bring out a difference between inflammation and normal cells. And so not everybody is able to suppress glucose metabolism. And so the short answer is that we do use PET scanning in specific circumstances with the nuances that we recognize. The scan is not always going to reflect specifically inflammation, but there's a lot of artifacts that could be complicated. And the other artifacts are if you've had established, say, coronary artery disease and a heart attack, you're going to see the superimposed injuries of other causes besides inflammation, other scar, other inflammation. And so I just want to say that it's both are useful in their way. MRI is more common, and both of them require expert review and interpretation who understand the nuances.
Thank you.
Lot too much information on that one, but I want to give you the right answer.
Thank you, Dr. Cooper. I have a couple of pericarditis questions. I've had pericarditis, and what are the chances that it will go away and not become chronic? And also, are there any known side effects for the new drug Arcalyst for chronic pericarditis?
I'll split that one with somebody. So in terms of Relanocept, which is Arcalyst, it's very effective. That and other anti-IL-1 receptor antagonists have been incredibly effective at suppressing inflammation due to pericarditis, probably over and above the standards of colchicine and ibuprofen or similar anti-inflammatory agents. But having said that, it's for recurrent pericarditis, it's not for first time. There's many people, and I wish Dr. Amazio was on because he published many
Dr. Cooper.
So in the meanwhile, I can reply.
Thank you for the rescue.
But we have to say that these drugs are very effective. But as Leslie is saying, they are very expensive. It must be said that they are very, very expensive. And they are very effective, but in specific subtypes. When you have a very high level of inflammatory biomarkers and recurrences. Otherwise, standard treatments like colchicine in association with ibuprofen, for instance, are very effective in most of cases. So most of pericarditis are treated with these drugs, and Massimo Emazio contributed to demonstrate that this very inexpensive treatment that is colchicine is a valuable addition to the standard therapy of ibuprofen. So this is the standard therapy. All the other drugs are just for patients with recurrences, but also with evidence of marker of inflammation that are very high, okay? Because they tested this hypothesis that these specific anti-inflammatory drugs are effective in these specific subtypes. Of course, pericarditis can be also associated with myocarditis. So the two conditions are often seen together. Mm-hmm. If you have a myocarditis, in my view, that is complicated by pericarditis, and this occurs in around 30 to 40% of cases, you have generally a high level, increased level of troponin. So my attention is mainly toward the presence of a myocarditis, because of course the muscle, in my view, is more important. But even in these cases, we generally suggest the use of these drugs like ibuprofen or colchicine, because they are effective on the pericardial disease and probably are not dangerous for the myocardium, okay? And another point is why the pericarditis are often associated with myocarditis. The point is that the portion of the heart that is mainly affected by myocarditis is the external layer of the heart, of the myocardium. So for continuity, inflammation can involve also the pericardium. That is the justification, because pericarditis and myocarditis are often seen together. And that is my question, my reply. I hope that I replied fully as Leslie was doing.
Sorry, Dr. Cooper, you were getting frozen there. So Dr. Amoretti jumped in to rescue us. So if you had anything special that you wanted to say that we didn't hear, feel free to say it now, I guess. Are you unfrozen? Dr. Cooper?
Can you hear me now?
Yes, you were frozen, so Enrico jumped in there and saved us. Is there anything that you were urgently trying to tell us that possibly he didn't answer for you? Okay.
No, he did a great job. You know, the only thing I was thinking about while I was listening was completely different. And that is that 17 people with giant cell myocarditis signed up for this call, and eight of whom had transplants, and that's an amazing number. I just want you to know, for a disease that's incredibly rare, to have 17 people on this call, I just want to recognize you without I don't know who you are, but to say that thank you so much for calling in, and we hope that we really hope that we are able to answer your questions. And if you aren't, you can always send Jen emails, and the group can get back to you. But thank you so much for joining. Were there any?
I can give you giant cell questions. People are asked that they've heard more about people surviving without the need of transplants. Is this a trend or a coincidence, do you think? And is it due to earlier detection, more awareness among the doctors, different medications? Do you have any thoughts on that? I'm sure you do.
Sure. So as I think people on this call know, that the earlier you make the diagnosis, the more likely that you're going to have successful treatment. And Dr. Amoretti and I and others have written a lot about when to do heart biopsy. And it's really important when you get a fulminant case of myocarditis, where there is ventricular tachycardia, bad heart rhythms, and low heart pump function, to get that heart biopsy quickly. So that's the most important thing. And part of this foundation is to raise awareness. This event today is just one part of what we do every single day to raise awareness about myocarditis in general, and specifically when to get to a center of expertise that can do a heart biopsy. So a little bit on just that little background is early diagnosis and thinking of the disease. Now, the outcomes currently are very good. We know from Finland, and we know from our experience and some other recent publications, that if you get a diagnosis early and are given appropriate therapies, which is supportive as well as immunosuppression, the likelihood of being alive at 1 year is 90%. There's an overall 90% survival and about a 10% mortality under the best of all possible circumstances. Now, unfortunately, many people don't get diagnosed early, and so the overall mortality for all giant cell myocarditis is much greater. But having said that, the likelihood of transplant's about 20% at 1 year because they just don't recover. So it's about a 70-75% rate of transplant-free survival under the best of circumstances. Now, of that group, some will still have heart failure. Some people will still have a cardiomyopathy, and they will require long-term heart failure management, maybe some immunosuppression as well for a long time. But about half, I would say today, in my estimate, of people with a new diagnosis of giant cell can eventually recover normal heart pump function and have full activity. And again, it's a remarkable thing for a disease that 25 years ago had 100% rate of death of transplant. So that's the and it's largely, it's this the people on this phone call, Candace and the foundation staff, Jen, who have done so much work to raise awareness that has made it possible for people to get the right therapy early. So those are the numbers as of today. If you make an early diagnosis, it's pretty good. You may require, new diagnosis may require advanced circulatory support. So what Enrico has studied extensively, the use of inotropes or mechanical impellers, that's a kind of pump, to support the heart for a period of weeks may well be necessary as part of that therapy.
Some of the survivors have asked, wondering for their personal thoughts, what the long-term survival is for a giant cell patient with or without a transplant. We know Candace is 20 years plus. Keep going strong, Candace. But I think people are asking.
I believe that if you have a giant cell myocarditis and you have a full recovery of the heart function, then you can expect a normal, a standard duration of your life. Okay, of course, about 20% of patients with a giant cell myocarditis have a concurrent autoimmune disorders, so like systemic lupus erythematosus. So this condition can affect can affect the quality and duration of life. It must be said that this is a drug that this is a disease, the giant cell myocarditis, that even if you recover, needs an immunosuppression long life. And in particular, with the use of cyclosporine. Cyclosporine is a safe drug, even if it can increase the risk of infection and even of skin cancers in particular. And what we know is that withdraw this medication can cause recurrence of giant cell myocarditis. At least we have the experience of some case like that. We cannot say that every person that withdraw cyclosporine has a recurrence, but we suggest, we recommend not to withdraw this medication if you are a survivor. Like for heart transplant, there is an increased risk of cellular rejection, and there is the possibility of a giant cell recurrence in the follow-up, even after heart transplant. The current data suggests that the overall survival after heart transplant is comparable to heart transplant due to other causes. So it doesn't, giant cell myocarditis doesn't seem to affect the survival after heart transplant. The survival after heart transplant depends on a lot of different variables. First of all, the age of the recipient. And I would say that fortunately, even heart transplant survival is significantly improved in the years. So we have even patients that are on that have been transplanted more than 30 years ago. So I would like to reassure folk that has been transplanted as a consequence of a giant cell myocarditis. I hope to have fully replied to this question.
I believe you did, and a couple of others that I have here too. You talk about autoimmune diseases. If you were to have an autoimmune disease and a history of giant cell, can the autoimmune disease attack the new heart and cause rejection?
You know, it's a very, the answer to that's a very subtle answer, because whether rejection itself is an autoimmune process against, you know, an allograft, which is from a different person, and whether you had autoimmunity due to the normal post-transplant process, or whether it was due to an underlying lupus or rheumatoid arthritis, you know, I think it would be very difficult to sort those things out clinically, or even on a research basis. But I would say that Chantal Elam, who is at Case Western University, did a nice paper on the post-transplant outcomes in giant cell myocarditis. And although there may be an increase in rejection episodes, the overall survival of allografts following transplant for giant cell myocarditis is similar or identical to transplant for other non-ischemic cardiomyopathy. And so I think that was what we showed in 1997 in that first paper, was that, in fact, the first paper was never designed to look at immunosuppression. It was designed to show that transplant was effective, because in those days, the discussion was, should you do any transplant for giant cell, because the recurrence would cause graft loss and it would be futile. And that was the point of the first New England Journal paper, was that yes, transplant actually is effective and the rate of graft loss is not different. And then multiple other groups have shown that since. But I just want to say that despite that possible increase of rejection, it's still not a reason to withhold transplant in giant cell.
Even if modern mechanical circular support allow a longer time on support, and that can really allow a recovery, because in giant cell myocarditis, what we see is the really impressive inflammatory infiltrate. So when you have even a drug that is effective to reduce these inflammatory infiltrates, then your heart cells need to recover after this trauma. So it's very important to guarantee a mechanical circular support, at least in patients with the presenting with the very bad conditions. And in my view, this is one of the key points that allowed an increased survival with the native heart for patients that had a giant cell myocarditis. And this is an important point. I would add a comment about autoimmune disorders, because we talk about systemic autoimmune disorders, but we have to pay attention also to inflammatory bowel disease, because we have seen that patients with the inflammatory bowel disease has probably an increased risk for myocarditis, and specifically for giant cell myocarditis. And I have to say that we have also several patients with eosinophilic myocarditis and inflammatory bowel disease. So it's important to control the inflammatory bowel disease to reduce the risk probably of myocarditis recurrence in these patients. And finally, another point: if a patient receives a transplant due to a giant cell myocarditis, and the giant cell myocarditis is due to a systemic inflammatory disorders, in the end, the drugs that are that can prevent cellular rejection are generally also very effective to prevent further flares of the autoimmune disorders, because you really dump the inflammatory response in these patients. So I do not see any contraindication for heart transplant in these patients.
Thank you. Thank you very much. Let's see. I do have another question for giant cell, and they're asking, does the recurrence, the chance of recurrence in giant cell decrease over time post-diagnosis? I'm sure they've all been told that you have a chance of the giant cell coming back, but they're asking, as time goes on, does it become less so?
That's a great question. There are two ways to look at that. Following heart transplant, the overall risk of recurrence is about 20%. And the time course is early in younger individuals and more aggressive, between 14 days as the earliest we've reported, and then the longest is 9 years. And that was in a patient from where I did residency. And so I think the risk is greater earlier on, and it does trail off with time, both in the transplant and the native heart. The risk of recurrence we reported in the native heart is 12.5%, which is probably similar, I'll call it, rather than less than the post-transplant risk. And almost all of those, in fact, all of them, occurred in people who did not have full recovery. If you had a normalization of your heart pump function following therapy for giant cell acutely, and you remained on appropriate low but continuing doses of immunosuppression for the first few years, then there was no episodes at all in all of our experience with recurrence. The recurrences in fact occurred in people whose ejection fractions remained low, say 30 or 40 or 45%. When we taper immunosuppression, you could see a recurrence, and that is where I think the risk is. It's not in the normal people who have fully recovered, to my knowledge. It's in the people who have not fully recovered. And that risk does go out as far as 8 years, is the longest that I've personally seen histologically proven giant cell recurrence.
Thank you. We have a few COVID questions that's been in the news a lot lately, and the word myocarditis has been linked to COVID often, and they're wondering, after getting COVID, is there a potential that an immune response could trigger myocarditis just in the general population?
I don't want to monopolize. Maybe there's so much to talk about with COVID. Maybe Jack and Justin, you, although you're in the pediatric world, maybe you and Enrico could start, and I can add in if there's anything you want me to. Obviously, it's something we work on a lot. All of us work on it every day.
So I can start a little bit. I mean, COVID, just to preface, is still something we're learning so much about. So in terms of, what are the cardiac implications for a COVID infection, I think we clearly know that it can affect cardiac function. In terms of long-term prognosis, I don't think we have any idea quite yet. I'll relate it to the MISC diagnosis. So clearly some children after a COVID diagnosis will develop this inflammatory response in their heart, kind of a myocarditis-like picture. We treat it actually very similarly to the way we end up treating some cases of myocarditis. We use immune modulation to help calm down that response. And many of these patients can recover quite quickly. Again, the long-term implications following a diagnosis of MISC, I don't think we know, and it's kind of to be determined. So I think it's clear that COVID can affect the heart. Exactly how that occurs, I think we're still figuring that out.
Okay, Jack.
I was just going to add, I echo, what Justin is describing. We're learning a lot as we go along with this disease. Early on, I guess late summer or late spring, early summer, on the pediatric side, we saw a report come out on this inflammatory syndrome. It's classically about 2 weeks after someone has had the exposure or had the infection with coronavirus. And the cardiac involvement, it can be a pretty wide spectrum. You can have abnormal findings on EKG, you can have abnormal heart rhythms. Obviously, you can have abnormal or impaired heart function. And we're also seeing a lot of coronary artery involvement. So the coronary arteries are the blood vessels that feed or nourish the heart muscle. And we can see evidence of dilation, sometimes maybe even aneurysms of those vessels, sometimes blood clots in those vessels. So it's a very peculiar process, and we don't have standard, so to speak, therapies for that, but as Justin described, we'll use things that we're fairly used to using or comfortable with using, things like steroids or dexamethasone and maybe some kind of fancy immune modulators, but we're still somewhat limited in what we can do with that. I have to say, the really fortunate thing for us on the pediatric side is most of our pediatric patients who get affected with this inflammatory syndrome recover very nicely. Even our most sickest patients who end up on heart-lung bypass machines, for example, something like ECMO, can have recovery of cardiac function. And so there is some good news to this story about inflammation post-COVID, at least on the pediatric side.
People are wondering if they should take the COVID vaccine, especially if they've had any form of myocarditis or pericarditis in the past.
I reply to this question. I believe so. Because in the end, there is no clear connection that this specific vaccination increase the risk of recurrence of myocarditis. It must be said that potentially any type of vaccination can elicit can elicit an inflammatory response and can potentially cause a myocarditis, but is an extremely rare situation. So in the current pandemic situation, I believe that it's better to be vaccinated to restore a normal life. And going back to adults regarding COVID, initially it has been shown that cardiac injury was quite frequent in patients with the COVID, and the presence of a cardiac injury was demonstrated by an increase of this biomarker that is that you can get that you can measure from a blood sample. And this biomarker is called troponin. Troponin is increasing in myocarditis, but also during a myocardial infarction, for instance. So when they noticed that that there was an increase of troponin, most of people thought that this was caused to an associated myocarditis. But in the end, it was not the case. Myocarditis after or during a COVID infection is not so common. The typical myocarditis that can occur during COVID, in my view, it's around, I mean, largely 1 in 100, between 1 in 100 and 1 in 1,000 cases of COVID-19. So there are very interesting registry. There is this American Heart Association registry that is collecting prospectively cases of cardiovascular disease that occur during a COVID-19 hospitalization, and they found that 0.3% of myocarditis occurred. This is a very interesting study. And in parallel, we have a retrospective registry of hospitalized patients with the COVID. This is an unpublished study yet, and we collected data from 23 hospitals in the US and Europe, and we found that among more than 50,000 COVID-19 patients that were hospitalized, we found just 53 cases of myocarditis that has been really well characterized. I mean, with proven findings on cardiac magnetic resonance or with histology. That means just 1 out of 1,000 cases. It must be said that this figure can be underestimated, because you can imagine that during March or April 2020, we were unable to perform a cardiac magnetic resonance because, at least here in Milan and Lombardy, it was an emergency situation. So we were unable to do this kind of evaluation. But nevertheless, I believe that myocarditis is quite rare, because in the last months, they have published some reports based on cardiac magnetic resonance imaging, where they showed that the prevalence of myocarditis was quite high after a COVID infection. But I don't know what is the viewpoint by Leslie or other experts, but I feel that probably in the past has been probably it was due to small cohorts of patients, but probably there was overestimation of incidence of real myocarditis.
Exactly, Enrico. That's spot on. That, you know, the COVID-19 virus, a coronavirus, is not a lytic virus. It's not a cardiotropic virus. For comparison, the rate of myocarditis in wild-type Coxsackie B is about 2%. And so this is much lower than that, but still, there are other forms of injuries. And so this is a virus that affects endothelial cells. The COVID-19 virus can affect certain inflammatory cells like monocytes, and those can have long-term inflammatory changes in different organ systems. And so there's a whole interest in post-COVID syndrome, which can consist in 10 to 20% of hospitalized people who are dismissed from the hospital more than 4 weeks later having some chest pain, or 20 to 40% having shortness of breath or fatigue. Some of that is deconditioning, some of that may be pulmonary, and some of it could be cardiac, but not myocarditis. And so that's a huge area of investigation right now. Many people who've experienced that are probably enrolled in some of those studies, but the next year is going to tell us a lot more about the mechanisms of the post-COVID syndrome. But as Enrico said, typical lymphocytic myocarditis is not a major player in the vast majority of those cases.
Yeah, I would agree with that on the pediatric side. We certainly have parallels with what you're describing. Early on, when we saw post-COVID patients, they were frequently being diagnosed with myocarditis. I mean, 25% in one report of post-COVID patients who had this MIS-C syndrome were being diagnosed with myocarditis. And, these are patients who didn't have MRI, patients who didn't have biopsy, who, because they had depressed heart function and a viral infection, were being labeled myocarditis. And you can have a systemic infectious process, viral, bacterial, whatever, that causes your heart muscle to be depressed and not squeezing normally. But that's distinctly different from an inflammatory active process within the heart muscle. And so I agree. I think we were overdiagnosing myocarditis early in this pandemic on the pediatric side as well.
Another question about COVID vaccine. In people who are immunosuppressed, what is the efficacy of the vaccine? Do you feel that it will work as well? Can you speak to this, anybody?
I can add some hints about this point. We know that the risk of patients under immunosuppressive agents is increased, at least based on data from transplanted patients, for instance. So if a transplanted patient get infection, the infection can result in a more serious COVID infection. And another point is that the serology that we measure, so the antibodies that form after exposure to the vaccine, is reduced in patients under immunosuppressive agents. So there are data from patients who receive a heart transplant that after 2 weeks after the second shots have just between 50 to 70% of response if they are transplanted patients. So there is for sure a decrease antibody-mediated response to the vaccination. What we do not know is if even patients with on immunosuppressive agents can have a proper cellular immune response. So we are not sure, at least 100%, that not having antibodies in the blood is equal to say that that person has no proper cellular mediated response against the virus is if they are exposed to the coronavirus. So this is an important point. Probably in the future we will understand if transplanted patient or immunosuppressed patient that do not have a full serological response need a third injection of this vaccination. It's something that we don't really know, and we do not even know if even normal, I mean not immune depressed individual need in the future a third immunization with a vaccine.
Thank you, Dr. Ammirati. Going back to giant cell, after you have a transplant due to the giant cell, they're asking how often should you be tested to see that the giant cell isn't coming back, and can it be diagnosed by MRI rather than biopsy?
You know, the short answer is no for MRI. You still need tissue. There isn't a specific pattern of MRI abnormality that would be specific for giant cell in the initial setting. I suppose if you had a recurrence, you could assume it was recurrent giant cell, but I still think biopsy is the way to go for that histology. The second issue is how often to be tested. We tried very hard over 20 years ago to have a multi-center study following transplant for giant cell to answer that question. And the questions of what are the ideal immunosuppressive regimens, what's the ideal frequency of biopsy, it turned out to be infeasible. What I've said to people, physicians who are caring for giant cell patients, is to be alert for the possibility of recurrence and to have a low threshold for biopsy if you have a clinical scenario with allograft dysfunction or changing post-transplant hemodynamics. Having said that, there isn't a specific frequency of heart biopsy that we recommend or AlloMap testing. It's because we never, that paper was not published and we never gathered the data. I don't know, Enrico or anybody else who's doing post-transplant work, if you have any feedback for that.
No, I don't know anything about that, and I have to say that the routine biopsy surveillance in patients after a transplant after a giant cell myocarditis is equal to other transplanted patients. So there is no difference, and at least in our center we transplanted 3 patients with a giant cell myocarditis. One patient died before transplant, unfortunately, and 1 patient recovered. So in the last, I would say 20 years, we had just five patients that had giant cell myocarditis. That is just to have a rough idea how rare you are people with a giant cell myocarditis. Okay, so you are special for sure. And but in any case, we don't know if but I really believe that it's a condition that over the time the risk of a recurrence decrease, as it has been previously said by Leslie.
Thank you very much. I have a question here about, I know we spoke of the desmosomal gene earlier. Someone is asking, how do you get tested for that mutation?
So it's quite, I mean, it's funny because there are several questions about this entity, and in my view, it's not really well described even in scientific articles. So that means that some patients are more informed than physicians sometimes. But in any case, we do not recommend to every person with a myocarditis to undergo a genetic testing for blood sampling. So it's quite easy for a patient to be tested. The point is how The point is how to read the sample and how to read the result of the genetic testing, because this is the difficult part, because there are a lot of variants, and these variants can have a different meanings, and variants can be combined. So maybe you have one, and when I say variant, I can probably more easily refer to a mutation or change. It's not exactly the same meaning, but it's probably more understandable. And that means that there is something in the gene that produces the protein that is altered. So what we have seen is that there are some patients with myocarditis, especially patients with recurrent myocarditis, that have a variant in desmosomal genes. What are the desmosomes? Are the proteins that links the heart cells, the cardiomyocytes. So it's important that they are important elements in the contraction of the heart. And what we know is that desmoplakin in particular is more frequently associated with myocarditis comparing with other desmosomal proteins. There are data that suggest that patients with desmosomal mutation are also associated with an increased risk of a specific cardiomyopathy that is called arithmogenic cardiomyopathies or arithmogenic right ventricular cardiomyopathies. In fact, the same genes are also associated with these disorders. So what we are exploring now is to check if some recurrence myocarditis represent an early stage of this inherited has an onset around 40-year-old, while myocarditis, in particular, this kind of myocarditis that are associated with these gene variants, have an onset around 20 to 25 years. So it can be that myocarditis it's a clinical manifestation that anticipate the occurrence of a cardiomyopathy. So if we think that could be an explanation, so the right recognition of patients with myocarditis associated with desmosomal gene variants is very important, because you can predict the occurrence of a future cardiomyopathy. So that's very important in my view, and that's an important point even for in the pediatric field, because sometimes it's strange to have recurrent myocarditis in children, and then you realize that there is something more, especially if you have a family history of cardiomyopathies or a family history of recurrent myocarditis, or unfortunately a family history of sudden cardiac death. Maybe Jack or Justin can add some comments about this point.
Yeah, I think we are just starting to recognize that on the pediatric side. I have had one patient with a desmoplopathy who presented with what we thought was myocarditis, sort of some classic features, a sudden death event that required resuscitation by a teenage girl's father. Fortunately, she survived, and the cardiac MRI had some of the classic features of myocarditis. We ended up doing gene testing on her just because of the profound way in which she presented. We did family testing as well, and one of the parents ended up testing positive also, but had normal cardiac function. And so I think it's going to be interesting to see how we move forward with testing for this particular type of genetic mutation in patients who we otherwise assume have myocarditis. Now, this patient that I had, there was no viral etiology that was ever identified, no viral cause. And so I think that also played into our minds about, exactly what is going on here. And we wanted to make sure we weren't missing something. And that particular patient presented with ventricular arrhythmias, which put her at risk of a sudden cardiac death event. And Justin, we're all on this community blog on the pediatric side for cardiomyopathies, heart failure, transplant, and there was a recent discussion about this, and so I know other programs are also seeing it on the pediatric side.
You speak of the arithmogenic cardiomyopathy. We have a few patients that actually wrote in a couple of questions. They were originally diagnosed with viral myocarditis, but it was later found out that they had ARVC, ARVD, and they were wondering, is it always inherited? Is it curable? And athletically, can you do anything if you suffer from this? I don't know, that's a mouthful of questions and asking for a simple answer, but
they are very pertinent questions in my view. We can treat patients with arithmogenic cardiomyopathy, but unfortunately we cannot revert this condition. Because there is a replacement of cardiomyocytes by fibrotic tissue or fibrofatty tissue. That means that we can preserve the remaining heart with drugs that are used in the heart failure syndrome, and we can prevent in patients at increased risk of ventricular tachycardia to provide an implantable cardio defibrillator that can prevent sudden cardiac death in patients that are at high risk for ventricular tachycardia. In my view, if you have a proven diagnosis of arithmogenic right ventricular cardiomyopathy with a genetic background, the risk of competitive sports is very high, in the sense that you can increase the risk of arrhythmias, and you can also increase the risk to develop a more severe condition. Probably this is due to the fact that in particular athletes have a tendency to dilate physiological the heart, and this sort of stretching on these proteins that link the heart cells can make progress the disease faster. So we generally do not recommend competitive sports in patients affected by this disorder, because it is risky.
Thank you very much, Dr. Emirati. I really hope that you've answered their questions. I know that you've answered my thoughts on it, looking at it. And we're just about done, I think. Do the doctors have anything else they'd like to add about anything?
I just want to encourage everybody who's joined us on the Zoom call to stay active with the foundation. As we transition globally, I hope, away from the COVID days, and we are able to do more regional activities, please consider joining in any of our activities across the United States or internationally. We're trying hard to make our work more relevant in Europe, where there's a huge burden of myocarditis, but the foundation has not historically been as active as it is in North America. So I just encourage everybody. I know there are people from 9 countries, I think, on this phone call, and wherever you are in the world, please do try to stay active, work with Jen and Melissa and others in the foundation to grow awareness wherever you are.
Hey, Les, just real quickly, it looks like someone on the chat had a question about inheritance of giant cell and what you actually see on biopsy.
Yeah, two things. We have looked very hard for family patterns in giant cell over a long time, and we've never found multiple family members affected. There are several families, one in Spain, elsewhere, who've had multiple members with inflammatory bowel disease, of whom one will get giant cell. And then, like Enrico has studied, we identified families who had recurrent myocarditis, but not giant cell myocarditis. A giant cell would recur, obviously, but we've recurrent lymphocytic myocarditis in Australia, in Europe, and in North America. But it's only been, that's over decades, but only in the last 5 years have people begun to identify gene patterns that could predict perhaps the risk of recurrence. And so the bottom line is no, there are no family members. I could briefly share my screen if you want, if I can show you a picture of what giant cell looks like. Let me, is that okay, Jen? If you
Yes,
want,
definitely.
If somebody wants to just see a picture of a giant cell, it's right here. Oh, it says host is disabled screen sharing.
Melissa, can you fix that?
Again, I can easily show just a,
All right, she reversed it, Dr. Cooper.
okay, here you go. So let me hit share. And I hope we have the bandwidth to do this. And if you can see here, I'll just show you 3 pictures here. This is what, and again, I don't know if you can see this histological slide, but this is lymphocytic myocarditis. And for those who are not into histology, the red pale cells that are kind of linear looking are heart muscle cells or myocytes, and the little blue dots are lymphocytes. And the dark area that looks like it's getting damaged in the middle diagonally, that's the area of cardiac damage. And so that's a classic Dallas criteria positive lymphocytic myocarditis. And this is just a small shot, a high power shot of a giant cell. And you can appreciate in the middle of this, there's a kind of a cell that has lots of nuclei. The nuclei are the darker little dots, and it's a giant cell. It's a fusion of macrophages. And that's the classic cell. It's not unique to giant cell myocarditis. Sarcoid and other infections and foreign body reactions look like that. And then one of Dr. Amirati's papers here on eosinophilic myocarditis, you can see the most common pattern, and there are many different patterns, but this is one where you get eosinophil-rich perivascular. The little circle there in the middle is a blood vessel, and with a clear white center. And then these cells that have little bits of red in them, there are quite a few of them surrounding that blood vessel. That's eosinophilic. So just for the 2 seconds there, these are the patterns we look for amongst many other patterns in specific forms of myocarditis.
Thank you, Dr. Cooper. Thank you so much for that. Thank you to all the doctors for sharing your knowledge and expertise with us today on these subjects. I would like to also thank all of our participating family members and patients in our program today. And I hope that your sharing your questions have answered so many questions that others may have had about the diseases that they had desire to find more about as well. While COVID-19 was new for us in 2020, along with COVID myocarditis, many of us have known that word myocarditis long before this. We are working at the foundation this year on a new education initiative to raise awareness for the word myocarditis, so that people understand exactly what it means. Most people don't really know what the word myocarditis is until after they've been diagnosed about it. But now we're trying to bring that awareness so that if a patient is seen by a doctor, just to bring that word up, if the disease, how the disease, how their presentation of their child's illness or their illness is not the norm for them, to bring that word up and just raise awareness. Could this be myocarditis? We know that it's a rare disease, but we do know that the earlier it is diagnosed, the better the outcomes. If anybody's interested in becoming a volunteer or ambassador to spread the word, please contact our office. The pandemic sadly has affected many of our fundraisers and caused them to be canceled. We still rely on the help of donations to carry out our mission of education, research, and emotional support for those affected by the disease. As Leslie said earlier in the program, we have had over 30,000, sometimes even over 40,000 new users have come to our website a month to learn about this dread disease. So this is not something that should not be thought of more, and we need to raise the awareness for it. And we need to help as many people as we can who come to us for information. We're continuing to be the only foundation worldwide providing up-to-date education on myocarditis, and a leading contributor to myocarditis research through our fellowship grants to young upcoming researchers on the disease. The video of this program will be on our website and YouTube channel within the next week. And I want to thank you all again for joining us, and we hope that you enjoy the rest of your day. You have a good day. Thank you very much. Bye-bye to everybody.
Thank
We
you.
appreciate
Bye-bye.